All right. Number 17.
We're back.
Yes. You traveled to Kansas City this
I was
week.
in Kansas City this week. It was pretty fun to get into a new market. I don't know much about Kansas City, trying to learn, and got to meet with big academic medical system there, KU Med, Children's Hospital.
Nice.
Spent time with some entrepreneurs, some investors. It was fun to get out and kind of learn about a new market.
That's cool. I was in Rochester, Minnesota, for the National HFMA board retreat, summer board retreat, because we have 2 a year. We love hanging out together. But man, if you've never been to,
I have not been to Mayo, but I've heard it's incredible.
It's pretty much indescribable. I mean, I didn't know what I was getting myself into going there. But man, it is. I mean, the depth of the culture, the lore around the Mayo family.
Yeah. I mean, when they started, there was nothing there.
Yeah,
like, it was the Western Front.
That's exactly right.
On their own. Yeah.
Yeah, and they built all the buildings and the foundation house and it's pretty remarkable, but incredible facility. It's interesting to be in a place where the sovereignty of the physician is still clearly culturally, the premier thing. You know what I mean? It is not moved into an administration first environment. The physician is still the sovereign there. Yeah. It's obvious. And they orient towards physicians as talent. And I think that's why they have so many great physicians there,
I mean, I complain about the spend and the quality, but the real benefit of the United States is we have places like Mayo that are world class by exponentially
leaps
better
and bounds.
Right.
So,
not that there aren't other places in the U.S., but there's an elite group of 10, 12 places. Mayo is certainly in the top of that are incredible.
It was inspiring. So thank you, Dennis Dolan, the CFO at Mayo Clinic, for hosting the entire HFMA board. We all loved it, and I certainly was very inspired. And now we're gonna
different
talk
culture
about
than the for-profits or the
it's
payer
not
systems or other
dude.
things.
It's not even in the same universe.
Yeah,
honestly. So with that, let's talk about the news.
Yeah. Yeah, it's always, I feel like I say this every week. There's a lot of news. There's always a lot of news.
Yeah, that's the good thing about, doing the show.
Yeah.
All right, so the first thing we're going to talk about, this Truepill news. I mean, this is obviously really big news, but you did a good job kind of going back and kind of figuring out when did this all start. So we're going to start with a story from August 3rd in Forbes that talked about the CEO leaving Truepill. Yeah,
so the two co-founders several years ago, I don't know, 6-7 years ago, started it. And they built it into a unicorn, both in leadership. And the second founder left. He was CEO for 6 or 7 months. The first founder was CEO, and then he left in January, I think, January, February. Mm-hmm. And so that was the first sign. I honestly didn't really care that much. Just felt like they were changing the guard and bringing in new talent.
Right.
And
right.
Not that surprising. The founders often move on after 6 years, whatever it is. So,
and they raised a ton of money in 2021. So super well capitalized. They were a unicorn. Important to say, they were a unicorn valued at $1.6 billion.
They raised probably $600 million roughly. They raised a lot of money over time, but they were well into unicorn status. They had a lot of equity value.
Right.
And for people that don't know, that they were one of the first sort of nationwide dispense from one place and ship drugs to you all over the country. And they did a lot of volume at that.
And they weren't just doing that volume direct. They were partnering with telehealth platforms as well.
Yes.
Right.
They would dispense the drugs that were prescribed by the doc in any visit, but primarily in telehealth visits.
Right. And in tech first telehealth. So, it's like you may have a primary care physician, I do, and sometimes I don't want to go in to see him. So we'll just do sort of a doxy.me session. And then he would say, okay, here's what I think you've got. I'm putting in a script at Walgreens, right? So that's like one way that telehealth and pharmacies sort of work together.
Yeah, and he is your main doctor. He has your medical records for a long time.
Yes,
you talk to the same person.
That's right.
Sometimes in person, sometimes over a telehealth visit.
Yeah. And sometimes it's just via text.
Yeah, sometimes via text.
Yeah.
That's harder to bill for.
Right.
But yes, then there are what you're calling tech first. I think that's probably a good enough way to say it, where there is no on-premise site where the docs work. It's all telehealth.
Right.
Hims and Roman were the first big ones.
Right.
Really treating, I know about it because I'm losing my hair. I never used them, but they really were treating hair loss, erectile
ED.
dysfunction. Yep. And it makes a ton of sense. We wrote about it 5 years ago. Things that are a little embarrassing to do in person are natural, like perfect for telehealth.
Right.
And that's great. We should get help to people that maybe are embarrassed to go in and talk about ED, erectile dysfunction, in person. But it also led to some bad actors.
Yeah. So Cerebral,
yes,
which was on the behavioral health side, that became infamous for effectively being a pill mill for Adderall.
Right.
I think they're out of business now.
Yeah. Oh, yeah. I think the DEA shut them down.
Yeah. I think Cerebral is done. So a story came out.
But Cerebral was not licensed to dispense drugs.
No, they were a telehealth platform.
Right.
So who was dispensing their drugs?
Right.
So a story came out in the Information, which I would imagine most of our listeners may not have even heard of, and certainly probably don't have a subscription to. But the Information is a heavily paywalled media company that really focuses on Silicon Valley. And so they do a really good job of kind of covering what's happening in the VC world, largely focused on Silicon Valley. Yep. And they covered this because it was a Y Combinator story.
Yeah. And it was a kind of a strange story, I thought.
Yeah. Well, the way it was
portrayed is bizarre.
Yeah. So the story is announcing, not really in the form of a press release, but clearly they had the information structured almost like a press release, that the company is cutting their share price 90%. And Gary Tan, who's the president of Y Combinator, but prior to that was a Y-Com founder, and after that was a VC with Initialized, partnered with Alexis Ohanian before they split. And Alexis
famous, like a guy you want on your board.
Yeah, absolutely. Yeah. Very, very well known, big, San Francisco, guy.
Yeah.
The president of the YC today.
Yeah. Right.
Departs.
He's leaving the board.
He's leaving the board. So,
but they're not raising money. So the reason I thought it was a strange story is they announced in the press that they were cutting their share price. This is a not traded company. It's an illiquid company. And we should talk through who the owners are. But Y Combinator, Initialized, which is where Gary probably was when he did it.
Well, so the article says that they disclose the share prices in updated articles of incorporation. So it seems like they're going through a pretty significant restructuring, and that's sort of where all this information came from. Other investors in the deal, Initialized Capital, which is that was Gary Tan's old firm, so that makes sense, and Oak, HCFT, big healthcare fintech fund. They collectively raised about $300 million from those VC firms and others. So these are blue chip VC firms that were in this deal.
Great firms and a lot of money.
Yeah, a lot of money. And so a 90% markdown from their peak in 2021. So we've talked about the 2021 vintage and what a disaster that vintage is going to be. So here's yet another unicorn that is now worth less than $200
it lost its
million.
Yeah. Just a unit now.
So as you get further down into the article, what you find is that the DEA alleged that Truepill had wrongly filled Adderall prescriptions on behalf of Cerebral. And this gets back to our constant discussion around Silicon Valley based VC invested firms in the healthcare space playing fast and loose in healthcare, particularly at the clinical side of things.
Yeah.
You can't do it.
We in Nashville, I think across the country in Middle America, have a different view of the healthcare regulatory environment than Silicon Valley does. I think they believe that innovation and startups lead the change and then the regulators follow. And that might be true with Uber, it might be true with Airbnb, but I don't think it's true. And this is another example where it failed in human health, where life is at stake. Now, whether college kids illegally getting Adderall to be able to stay up all night studying is life or death is, I don't know, but the DEA is serious. They do not allow controlled substances just to be thrown around like that for a good reason.
No. And look, a 90% markdown.
I mean, they're worth nothing.
That's brutal.
The company's worth nothing.
That's brutal. So all of that capital that was invested, by those firms, it's gone.
I mean, think about it now. Like if we were going to start a telehealth company, would we use them to fill our scripts?
No, not now.
No,
not now.
Well, after the DEA came out, you wouldn't. So like, it's 90%. I think it's 100%. There's nothing left there.
Yeah, I mean, maybe there's some technology that can be, sold for parts or something like that. But
yeah.
Look, I mean, it's a brutal story, right? It's a brutal story, and what I think is really interesting is that Truepill was behind Cerebral, right? So they were the pharmacy fulfilling Cerebral's prescriptions, right?
Yeah.
That were issued. And this is
an MD or someone wrote a script, and the pharmacy, Truepill's pharmacist, filled it,
right?
And the DEA is connecting them, I think, saying they should have known that this volume was not possible, or something similar to that.
Right.
Which I don't know if that's fair or not, but again. You don't want to get sideways with the DEA.
Yeah, look, I don't know enough about operating pharmacy to know what the actual relationship or auditability of the relationship between a doctor and a pharmacy, and sort of tracking the patterns of what a doc is submitting in terms of their script patterns. Yeah. I don't know enough about that, but what's clear here is the DEA has tied Cerebral and Truepill together. In what they've alleged. And, that's pretty serious. I mean, I've never had a company have the DEA come in, but I don't ever want it. Like
it's not a good day.
That's scary.
Not a good day.
Yeah. So I'm sure I'm sure Gary Tam was like, I'm getting off this.
Right. Exactly. I'm running the other way.
Yeah, dude.
Exactly. Yeah. I mean, I'm chairman of Script Drop, and we deliver drugs all over the country. We intentionally are not the dispensing pharmacy.
Right.
So we partner with other pharmacies.
But you're the deliverer.
We're the delivery. And we did that strategically to partner with pharmacies.
To not compete,
to sort of enable them, because we were trying to compete against PillPack and Truepill and all that are trying to displace the pharmacy and kind of knock them over.
Right. You were enabling the pharmacy to have this delivery capability.
Yeah. And now that I read this article, sort of a very good side effect of that is it's also not my responsibility. Like, we're not the dispensing pharmacy.
Right. So, you don't have that liability.
Right.
Yeah. So that's very good. Okay, let's move on to the big CVS Caremark story with Blue Shield. This is a big story. Came out on the 18th. And basically, I mean, straight up Blue Shield has backed away from Caremark, and what I think is really interesting is they're backfilling it not with another PBM, but with some array of companies, and they cited Amazon and Mark Cuban's Cost Plus.
Right, and they are concerned about the price of drugs and trying to find a solution that will be less expensive for their employers. The cost of drugs and the number of drugs that are effective is growing really quickly. I think every employer I talk to is trying to figure out, okay, how do I navigate this and have some visibility of what it's going to cost. And then you pointed out, which I think is probably the better way to read it, is they're a payer competing with CVS.
Yeah.
And so they don't want to use their platform and enable them when they're competing against them for large employers and other things.
Yeah, I mean, this to me feels like continued evolution of vertical integration that we call Payvider. You know, all of the really strong ones have a PBM built in. Optum has a PBM. Obviously, CVS has a PBM.
Yeah. Cigna has one.
Express Scripts, right? Is there a PBM? Yeah. So, you know, it's part of the stack that you have. The Blues have been behind on this entire evolution. Part of it is because they're very fragmented. We have seen Elevance, which is a very, very strong blue, sort of say we're going to, you know, was Anthem say we're turning into a full on Payvider. But I mean, I think if you just look at that overall trend, this makes sense. And I'm not entirely sure. I mean, you know, the shares of CVS tumbled and UHG took a smaller hit than CVS. Obviously, they didn't lose the business, but the analysts in Wall Street just sort of extrapolated it as a PBM, you know, issue.
Well, but PBMs have been a cash cow. I mean, they make money for these firms. So.
Yeah, but I think they're just going to get placed as part of the vertical stack. That's what I think is going to end up happening. And I think the key, what we talked about before the show, was that you didn't have Amazon and Mark Cuban's Cost Plus as players even 3 or 4 years ago, right? And so now that you have these like true, hyper transparent, generic platforms, you can kind of more say, okay, well, I don't need a formulary for that at all. Yeah, I can just go direct with absolute transparency, don't have to worry, and I can
maybe 70% of the formulary you can go to a fully transparent platform. Yeah, and you have at least 2 choices. You have a couple choices.
Right. And I'm sure, you know, at the volume that they are going to be buying, they will get better than advertised rates from Amazon and Mark Cuban. Yeah. You know, so some of the margin is going to, you know, go away. They could just negotiate that. And then for the more expensive, you know, designer drugs or the specialty pharmacy stuff, they'll just figure out their own path for that. And
they're going to end up building their own kind of focused PBM for those drugs that they care about.
Yeah.
Or maybe maybe the Blue Cross Association will, or there'll be some solution for the Blues.
Something will come up for that. But I think what is interesting is that the new hyper transparent generic, you know, drug distributors are creating optionality and really putting a dent into the PBM. And this was the intent. This was always the stated intent was, you know, the PBMs are gouging middlemen. And I think this is a really big move.
I mean, it's difficult for CVS's strategy, but it's great for everyone else. Right? I mean, every employer, every, you know, someone that's in a fully insured book, the drug cost is the biggest cost, and having a whole nother set of ways to find drugs. I mean, it's often less expensive for me to go outside the coverage that I have and not even use it and just pay the cash cost.
Right.
Which is crazy, but that's how I'm getting some of my drugs now.
Yeah. And I think this just further, you know, I think we have stories every week that just indicate that people are not going to sit back and just keep paying more than they think they should. Like, we're going to keep seeing moves be made around lowering the cost. This is, you know, some of it's going to come in the form of closing hospitals. Right. You know, it's going to happen in all these really brutal ways, but deals are going to be unwound, new deals will be formed, things will be shut down, things will merge, and it's all around cost. Everything costs too much.
Yeah, and I think there's something around complexity for the sake of sort of hiding where you're making money and making it super confusing for the employers to even understand what they're buying.
And that's healthcare, isn't it?
That's the entire system. Yeah. And I think that is on a decline over a long period of time. I mean, it's a pretty complicated market, but the PBMs have been sort of in the spotlight by Congress and all kinds of people because, I don't know, they are. It's everyone knows that they're very complicated and they're making money somehow, but they kind of obfuscate exactly how with rebates and all kinds of complexity.
Yeah. Yeah. I mean, it's really interesting that Mark Cuban was able to come into this space and become a player.
Yeah. Well,
don't you think that's like?
I mean, I love to watch Cuban. What I'll say about him is he was a big investor in Truepill. And then he also has, I mean, he just sort of sees a theme and plays everything he can play to try to learn, which is a good strategy.
But this is his venture.
Thing. Right.
Yeah.
I think he probably seeded a bunch of things and was learning and then decided, well, I learned from that. They're clearly in trouble. I'll do my own thing.
Right. Well, I think it's really cool. I mean, because he's going to make a lot of money. And he's going to provide optionality that's going to lower the cost of care. And to me, like this is,
it's great.
There's so much opportunity for innovation like this, right? At scale, how are we going to lower the cost of care? So, hats off to Mark Cuban for coming in the space and actually meaningfully making an impact.
And Amazon continues to put the end consumer as a priority. And that's helpful. I mean, they do it in all kinds of markets. It's challenging when I'm competing against them.
Of course.
But as a consumer, they're great.
Yeah, they're going to consistently drive change. I mean, I'll give Amazon their due, but I think to me, it's more impressive for Mark to sort of enter on his own. And be in a league with Amazon as part of what Blue Cross Blue Shield is going to look at, leveraging. So continuing to talk about the cost of healthcare and the obfuscation of how the financing works. Story in the Wall Street Journal this week that is more bad shenanigans for hospitals, largely for community hospitals. Onesie twosie, safety net hospitals, and it's actually about landlords.
Yeah. So this company MPT. They buy any kind of medical building, and then they lease it back to the same hospital that used to own it. And so there's a lot of hospitals that have owned the building and the dirt that the building's on for decades, maybe in some senses for centuries.
Yeah, it's been an asset.
Yeah, it's been an asset. They really haven't. They've maintained the building kind of, but they haven't really focused on it. Right. They're treating patients.
Right.
And MPT has worked with a whole bunch of hedge funds, private equity funds, different groups to help them monetize that asset, meaning they buy the building and they give several $100 million to the hospital, and then they sign a lease with the hospital so they can lease back the building.
Mm-hmm.
And in theory, that can work well. Like if the price of the sale is right and the lease is fair, I would argue maybe hospitals shouldn't be in the business of owning a bunch of real estate that they can't really keep up with.
Right.
But it also leaves, again, lots of complexity where you might pay a little bit extra and then charge a really high lease. There aren't a lot of comparables to know what the square foot price should be.
Right.
And so they have done this for a long time, and now some of those leases are just unsustainable, and the hospitals are not able to pay it. The money that they got has evaporated.
Right.
They've spent it on whatever, and they don't have any money to pay the leases now.
Yeah, and I think part of this, first of all, this is at least they're framed in this Wall Street Journal story, which I think they don't take their journalistic integrity lightly here, as America's biggest hospital landlord. So, I just talked about how I was in Rochester, Minnesota. Mayo owns all their buildings, right? When we talk about the landlord, we're not talking about the Mayos of the world. We're not talking about the HCAs of the world. We're talking about these hospitals that are struggling. And when I was trying to find an analogy for how we might explain this to the layman, it's kind of like the reverse mortgage thing, right?
Yeah, that's what it's like.
It's a struggling individual.
Yeah.
They've got this
They're
asset.
trying to deal with their retirement. They have an asset, and they want to keep living there. But they don't know what it's worth.
Right.
They don't know anything.
Right. And they need money.
Yeah.
They need cash.
Yeah.
So they sell it, but then they gotta pay rent.
Right. So all of a sudden now you're paying rent for the house you've lived in for 40 years.
Right.
That's how these hospitals are.
Right.
And sometimes Steward Healthcare is probably the biggest one. It's maybe like a $10 billion, $12 billion health system.
It's pretty big.
Pretty big.
That's
health
pretty
system.
big, actually. Yeah,
it's a for-profit. They were spun out of the Catholic system, but then a bunch of for-profit owners have had it. They don't have a coherent strategy that I can tell. Mm-hmm. They're the biggest participant in MPT. But you're right. Overall, MPT, I looked into it. They have I think Wall Street Journal says they have about $20 billion in medical real estate. And they have been caught. The Wall Street Journal caught them reporting earnings using a transaction that was not closed, not complete.
They said it was complete. It was not complete.
Yes, and so it helped them meet their earnings for the last quarter.
Ooh, that's bad.
Yeah, they propped up their own earnings with this transaction, and the regulator has not approved it, and it's not clear they're going to approve it because the regulator. I mean, this is back to this what we were talking about with regulators.
Right.
They are not comfortable that it was a arm's length fair transaction. Now, maybe there's no. I think MPT is saying there's no other alternative. No one else was bidding, and that's true. But the fact is, they reported earnings as if it was closed, and it's not closed. And I think that's not allowed. You can't do that. So that was the main story. But then when we started looking into it, there's a second story that I think is pretty interesting about another hospital.
Yeah, but just one other thing here. So a lot of MPT's acquisitions came from private equity firms. So
right.
There's obviously a consistent scrutiny of private equity in the hospital space specifically, buying hospitals, doing the financial engineering to sort
right.
of turn to a 2 to 3x return. MPT has been buying a lot of these hospitals from private equity firms.
Right.
So private equity firms have been able to generate lots of results, lots of earnings. And we from Nashville, having watched many different playbooks of how you grow, have seen some things work well and some things not work so well in terms of just acquiring lots of hospitals across the country, right? HCA has been an incredible executor of this model, very, very diligent in their assessment of the markets, of the, of the facility itself, of the management teams before they make an acquisition, and have rarely made a misstep in their network.
I mean, is the population sort of in the normal distance away from the hospital that you would go if you got hurt or you need a new hip or whatever? You wouldn't fly to California to get a new hip.
Yeah,
right?
but they also look at the economic makeup of the market.
That's what I mean. So they want to make sure it's growing. They want to make sure the population is good size.
Right.
You have inflow and young families that are going to have kids. There's a whole bunch of research that goes into whether a market and then a facility in that market is attractive or not.
Right.
Not simply how many beds it has.
Right.
But
some take the strategy of just more. Buy it up, have the scale. Some will go, they probably do some margin of error. 10% will go bad, but the 90% will continue to grow as an asset base. And
that, and then sometimes they have other financial engineering strategies that are going to work.
Yeah, that's
no
right.
matter how good the hospital is. Well, I mean, this isn't an operational thing. This is, we're buying this asset. It has an operating business, but it also has the land and the buildings.
Well, sure.
And we can monetize that.
Yeah, well, I mean, that works if you don't think that the percentage of hospitals that are projected to close are actually going to close. But, I mean, there's a pretty nasty trend out there in terms of how many hospitals are projected to close over the next 5 to 10 years. So, I mean, if you're looking at that as your operating business as some form of, risk mitigation.
Just depends how long you think you're going to be in it.
Yeah, that's right. That's right.
If you are...
Well, who are you going to sell it off to as a sucker, right?
Doesn't matter.
Yeah.
Right. So, I mean, just I don't know the facts, and we haven't done enough research, so I need to say that. But there is a strategy of buying up a bunch of facilities that own the building, monetizing the building, paying a dividend to the owners, which are the private equity firm.
Yep.
And then you have a highly leverage. It's lease leverage. So it's a little different than a lot of private equity deals. Everyone knows about where they put kind of traditional debt on the company. A lease is a form of debt.
Mm-hmm.
So you leverage it up a lot. You pay all your equity back. You have your return already built in.
Yeah.
And then if they operate it really well, then maybe you can sell that asset. But if it happens to have troubles, then you already have your money. And it's in a corporation. You don't have liability in a bankruptcy. And I'm not saying that the private equity firms did that or that we have looked into it, but that's a financial engineering strategy.
It's a model,
that you would do, and you don't care necessarily about. It can't close like in the time frame I hold it, but you want to hold it 3 to 4 years, so you probably could ride it out for that. Anyway, I don't know if they did that, but MPT has done a lot of these deals very quickly.
Yeah, so a few months back, March 31st, there was a very specific story of a single hospital, Watsonville Community Hospital in Watsonville, California. It's the small city's only hospital, and it went bankrupt. Hospital went bankrupt.
Right.
And part of it was around the rent.
Yeah. Who's the biggest creditor? MPT.
MPT. And, why would a listener care about Watsonville, Community Hospital? Well, you might not care about Watsonville because you don't know about it, but you might know about Martinelli, which is the apple juice and apple cider company.
Yeah.
Maybe as a kid, you got that, or during the holidays, you have like a couple of bottles of that apple cider in your house. So Martinelli's, that's their town. As a company town, that's their town. They have a bunch of farms, and they have a bunch of a very large Latino farming workforce.
Yeah,
that's
and
there.
This is, whether you like their cider or not, this is an hour outside of San Francisco in America, and that town should have a hospital, or like it has to somehow take care of the people. If you get in a car accident, you shouldn't have to drive an hour to the hospital, or that's challenging. That's a new kind of America if we don't have hospitals in these rural areas.
Yeah. So in this company town, right? And Martinelli's is a brand that many people will recognize.
Yeah.
They lost their hospital because it went bankrupt, and they are trying to raise $70 million to buy the hospital and save it from closure. And that's just to
pay the debt off.
Yeah. That's just to save it.
They still got to operate it.
That's right. And so that just kind of shows you the kind of situation. And that's a town that actually has a business that's doing well. Not all towns even have that.
Right. So we talk about this sort of in the abstract, that there's a lot of health systems that are struggling. They don't have the right payer mix or something. And all of that is true. And these stories just made it much more real to me. Like, there are situations where, whether it's an intentional bad actor or unintentional, the hospital got in trouble with too much lease debt. I don't know where the money went that came in from the sale of the buildings, but they don't have it anymore.
Yeah. Well, what do you think that the payer mix is at Watsonville Community Hospital?
I think it's all government, or I think it's 80% government.
Well, that's where the money went to cover charity care and negative margins.
Yeah,
that's where it went.
Yeah. Sometimes, other times, it is owned by a for-profit group.
Sure.
And it's a combination of those things.
Yeah. So anyway,
we don't have the answer.
Story.
There's no real answer. This is ongoing, and we as a country have to figure out, how are we going to deliver care to these communities?
I just think it's important for us to keep trying to pull apart. Well, first of all, tell specific stories about hospitals closing. Like to me, I drink Martinelli's every year during the holidays. I don't drink alcohol, right? So when people start breaking out wine, like, I kind of reach for some Martinelli's or something like that. And so that kind of brings this home for me. I'm like, okay, like that company and their workforce, this was their hospital. Right. And I didn't know that in March their hospital went bankrupt and they're trying to raise $70 million. I didn't know that. And now I know that the reason is because of this MPT, real estate scheme, basically.
Yeah. And I know that, I have to say, there are purposes where a sale leaseback can be fine, right? Like, if you set the leases correctly and you're running it appropriately, and you use the money to improve the facility.
Sure.
Maybe you use it to buy some other diagnostic machines, or
Sure.
you upgrade things.
Sure.
But there also can be used for bad purposes too.
Yeah. Yeah. So, and then final note we'll make sort of on just how difficult it is for providers right now. Modern Healthcare came out with a story on the 23rd showing that bankruptcies are mounting in the nursing home industry. I mean, I don't know what really to say more than this is, terrifying as we are reaching a place where the boomers are going to really start to flood our healthcare system.
Yeah. Look at the chart. I mean, it's really difficult to run a nursing home, anything in sort of the elder care space, but nursing homes are probably one of the most challenging areas. And it's growing kind of alarmingly quickly, the bankruptcies.
Yeah, so there were 12 in 2022, there were 13 in 2021, there are projected to be 20 this year.
Right.
I would imagine some of that is because many of the relief funds that came in during COVID-19 have expired.
Yeah.
And so that's sort of the end of that. And
I think it's similar to the health systems as we've been talking about. The nursing homes don't really control their pricing. Right? If it's government paid, they don't control pricing at all. If they have a mix, they can set their private pay, but they are subject to having to pay workers more, and the price of energy going up, and everything is going up. We have inflation, and yet they're not getting any more revenue in.
I want to read these two paragraphs just to really put a finer point on this. Among those filing Chapter 11 was Evangelical Retirement Homes of Greater Chicago, which operates Friendship Village in Schaumburg, Illinois. The large nonprofit continuing care retirement community offers skilled nursing, assisted living, and independent living. In its June bankruptcy filing, Evangelical Retirement Homes listed $10 million to $50 million in assets and between $100 million to $500 million in liabilities. In Rhode Island, 3 of the state's 79 nursing homes representing more than 450 beds are in receivership. Herbert Health in Smithville, Trinity Health in Woonsocket, and Pawtucket Falls Healthcare Center in Pawtucket Falls. A receivership is a process designed to allow a company to restructure its debt while avoiding a bankruptcy filing. So, I mean, this is 450 beds.
Yeah, it's terrible. And okay, they don't have enough money to pay their debt, but where do the people go? There's probably 430 people that live there.
Right.
And I don't think there's anywhere that they can go.
No.
So,
and think about the families that are, trying to care for the loved ones. I mean, you and I both have
we
aging
both
parents,
have it. Right.
And I mean, I'm just scared for our generation trying to take care of our parents where this infrastructure is falling apart. It's not viable.
Yes. And we've been sort of kicking the can down the road year after year after year, just like, well, let's refinance that debt. We'll have zero interest rates forever and just kick it out. We'll never actually have to pay it.
Right.
And now with interest rates coming up, you can't do it. And so that I think that's part of this too, is that they can't refinance it.
Yep. All right, we're gonna stop and
on that happy note. Hear from Doug Edwards.
Yeah, talk about Jumpstart Foundry.
Thanks, guys, for the opportunity to talk about our pre-seed fund, Jumpstart Foundry. My name is Doug Edwards, CEO of Jumpstart Health Investors, the parent company of Jumpstart Foundry. We're so excited to be able to talk about early stage venture investing, certainly the need for us to change the crazy world of healthcare in the United States. We are spending 20% of our GDP, north of $4 trillion a year on healthcare with suboptimal outcomes. Jumpstart Foundry exists to help us find and identify and invest in innovative companies that are going to make a difference in healthcare in our country. Every year, Jumpstart Foundry invests a fund, raises a fund, and deploys that across 30, 40, 50 assets every year, allowing ease of access for our limited partners to invest to help us make something better in healthcare. Some of the benefits of Jumpstart Foundry is there's no management fees. We deploy all the capital that's raised every year in the fund. We find the best and brightest, typically around single-digit percentage of companies that apply for funding from Jumpstart, and we invest in the most incredible, robust, innovative solutions and founders in the United States. Over the last 9 years, Jumpstart Foundry has invested in nearly 200 early-stage, pre-seed stage companies in the country. Through those most innovative solutions that Jumpstart Foundry invests in, we also provide great returns and a great experience for our limited partners. We partner with AngelList to administer the fund, making that ease of access not only with low minimums, but the ease of investing in venture much better. We all know that healthcare is broken. Everyone deserves better. Come alongside us with Jumpstart Foundry, invest in making the future of healthcare better, and make something better in healthcare. Thank you, guys. Now back to the show.
All right, we are going to actually have a happy note here.
Yeah.
I actually know somebody who sent a note in our group chat that said that they had their student debt relieved, and I was very, very happy for this person. They just welcomed a new baby into their family, and it's great.
Yeah.
And I think what's really good is to understand sort of why the debt was forgiven. So in this Bloomberg story that's covering it, we talked about it last week. We saw it in the chart that was in the Wall Street Journal. We couldn't really explain it, but yes, $39 billion in student debt for more than 800,000 borrowers has been removed,
forgiven.
Forgiven. And the key is that these are borrowers that had enrolled in an income-driven repayment plan and had made monthly payments for at least 20 years. So basically, the terms of their loans should have put them in a place where they were done with the debt, but they were not. And so they found a way to sort of get it done and relieve some of the pressure in the economic system, but nowhere close to the entirety of the tsunami of student debt payments that are about to be turned back on in September.
Yeah, I mean, I think you've been making payments for 20 years, and I don't know how they set the income repayment plans, but it's tied to how much money you make. So you've been paying whatever the government tells you to pay every month for 20 years. I feel like we should let them off the hook.
Yeah.
But there's a lot of people that aren't included in that.
Yes, there are a lot of people, because what's the total number?
I think it's 1.7 trillion. And so, this is let's call it 40 billion, 0.4 trillion.
Right.
But that's, there's still 1.3 trillion.
Right.
That, they haven't been paying for 20 years. They've been paying for 5 years or 10 years or whatever.
Yeah, so you found this report that Fidelity put out, and it's just talking about saving for college and all this other kind of stuff.
Fidelity's trying to get you to do a 529 plan or whatever. But then they have this extra little piece talking about the federal, policy that now the delay of payments is ending.
Right.
And it kind of scared me. So I wanted to talk about it. It says 65% of college students currently taking advantage of the federal payment pause say they have no idea how they're going to start repaying their loans once the emergency pause is lifted this fall. So that's almost 2/3, 65% of people. It's in September. I need to find the exact, but it's in the next month. And now maybe if Fidelity calls.
So if we were to evenly distribute it, we're talking about north of $700 billion. That people have no idea how they're going to start paying.
Like they already are tight on their, like they make some money, but then they buy food and pay rent and whatever. And it's been maybe two or 3 years that they haven't had to pay this student loan. So they've gotten used to their cost of living without that. And they don't know what they would cut. I mean, are they going to not have a car anymore? Are they not going to eat? I think maybe if Fidelity calls, it might just be simpler to say, well, I don't have a plan, and hope maybe that filters up and the government does something for me. But I think it's pretty clear there's going to be a lot of pain, a lot of cutback in spending where it's not that easy to cut back. They're not saving the money and put it in a Fidelity index. They're going to have to cut back on something that they don't want to cut back on.
I mean, look, just telling the truth, when I was making my sort of social and economic mobility climb, I wasn't even aware of 529s. Like I just didn't even really know about them. And, I've been fortunate to have some events because I got into the startup world where I had a couple things sort of pan out. And so I get, some.
You get like a block of money and then put it away for your boys.
Exactly. And then, one of my boys decided to go in the military and the other one went to in-state. Right.
Yeah,
and so I've been very, very fortunate that I can basically write the checks and it's we don't have this debt issue in our family. But,
I personally had student debt and I was 49. I'm 52 today. I was 49 when I finished paying it off. It was right before the pandemic. I was paying it off for whatever that is, like 30 years. And it was fine. I mean, I made enough money to pay it and do other things.
You were never worried about it, but it took a long time.
Took a long time. And, we won't even get into the real value of the degree versus where it was when you graduated from school in terms of, return on investment and earning potential from that and just real dollars on the return. It's terrifying. And why do we talk about it on a show that's supposed to be about healthcare? Well, because healthcare costs too much and people with no money or not enough money, they end up on Medicaid. Yeah.
And that's a system that is not working very well right now, right?
Yeah, and that's true. I also worry that one of the places they'll cut is going to be like going to see your primary care doctor.
Oh, for sure.
Or like your maintenance medication or whatever. And that's going to increase chronic disease.
Yeah, of course, because we're still a fee-for-service incented model.
Yeah, so 2/3 of people don't know what they're going to do. On average, I think it's something like $1,400 a month. That is going to come out of retail sales. It's going to come out of healthcare spending. It's going to come out of, I don't know, the new car sales are going to be down.
It's going to increase bankruptcies.
Yes.
Which is going to make a lot of people not credit worthy.
Yes.
Which is going to definitely decrease spending and all sorts of consumer activity.
Kind of cascading.
Yes. Yeah. Right. All right. The government has been really active doing things. So we just talked about the student debt piece, which was in the works for a while. But there have been a couple of business moves that that have come into play. So the IRS added a new tax.
This was really shocking and pretty brilliant, honestly. Part of the Inflation Reduction Act, I don't know how this fit in with that title, but they are taxing share buybacks by publicly traded companies at 1%. So 1% of the money that's spent to buy back shares by a publicly traded company. PayPal is in the picture here because they just paid $24 million in taxes, I guess because they bought back whatever, 240 million.
Yeah.
And so it's kind of a brilliant tax strategy, really, because companies are still going to buy back shares, but they'll buy back somewhat fewer shares because they have to pay this tax. I don't know what I think about it. It's kind of an interesting way to raise money. It's surprising that it just happened and I didn't know about it. I don't think anyone really knew about it. It's
a new corporate tax, but it's on a very specific behavior, and it's on a behavior that I think is generally not very popular, right? It's on a behavior that is seen as just corporations, not investing in R&D, not paying employees, not taking care of their communities, but just taking their money and buying their own shares and enriching their own value.
So I think that's true. I think it's also true that the IRS hates it because it's a way you can give shareholders a benefit, but you're not paying a dividend, which is taxed.
Yes.
It's like a tax advantage dividend.
Right.
And so I think that's probably one of the reasons that they are taxing it now. And it's gonna raise a lot of money.
Yep.
So that'll be good for the U.S. balance sheet.
Well, it'll be interesting to see whether or not it has any impact on this strategy. It could be that 1% is exactly the right number, that it's like, okay, fine, we'll take that hit, but we're going to keep doing it.
Yeah. So what the Wall Street Journal talks about in the body of the thing is 1% probably is fine.
Yeah.
But not many taxes have stayed at their original, like, first time it comes out. So if it creeps to 3-5%, now it's going to really impact like the company's ability to do that.
Yeah. And by the way, just to correct ourselves, so we said 240, but no, that would be 2.4 billion, right?
Because 1%,
Yeah,
not
1%,
10%.
not 10%. Yeah. Okay. Just want to make sure we correct ourselves in real time. I was like, I don't think that's quite right. Okay, so this is getting into our business in a very specific way.
The IRS attacking someone else is not a big
Who
deal.
cares? Who cares? Publicly
Right.
traded companies, I don't give a shit.
Yeah.
The SEC takes on private equity hedge funds, and it doesn't say venture capital, but it should.
It is VC.
It's VC. Yeah. So there's a bunch of sweeping new rules around transparency and driving down fees. But one of the big things is that side letters, or they say certain side letters, but that to me that felt like kind of the legalese of it. Certain meaning all probably.
You can't have a side letter that's not disclosed.
Okay, so let's talk about what a side letter is.
Yeah.
Almost nobody who's listening to our show knows what a side letter is.
Yeah. Yeah. So when a VC or a private equity fund or a hedge fund, all of these kind of private pools of money are raised with what's called a limited partnership agreement, which just is how the VC firm or the private equity firm works with its investors. And it kind of lays out the general guidelines. We're going to raise X amount of dollars. We'll raise, I don't know, $500 million. And we charge some fees to run our business. And then if we have profits, we get a share of that. And there's a lot of details of how the people that are investing in money, the limited partners, are requiring the general partner do its job. That's all laid out in one document everybody signs called the LPA. And that's the basis for all the funds. And then often there are side letters which are sort of attached to that for one particular investor that they want something specific. So that maybe they want the right, a very common one is they want the right to co-invest alongside the fund in certain kinds of deals, maybe in all the deals or in some subset of it. And you can be as creative as you want to be. It depends on what the LP and the GP are willing to agree to. But a lot of firms have many, many side letters because the standard LPA is sort of a general document, but then there's all kinds of exceptions. And that is not going away, but you have to disclose all of that to everybody.
I mean, I think there's a couple things here. One, the SEC has a split. So Gary Gensler is the chair. Hester Pierce is kind of the Republican consistent dissenter to Gensler. We've heard a lot about them, quite frankly. They've been very active fighting. He's obviously winning because he's the chair and he's got 3-2, sometimes 4-1. Sometimes she's the only objector.
Yeah. This was 3-2.
This was 3-2. But, he has made a lot of noise in the crypto space.
Right. That's where it's been most public.
It's been most public with him.
Attacking Coinbase
Yes.
and lots of places, but Coinbase is probably the biggest name most people know.
Yeah.
That he's basically saying all the coins that are traded on Coinbase except for Bitcoin are illegal.
They're securities.
They're securities, and Coinbase is not
registered,
running it correctly.
Yeah. They're not registered to be able to be in exchange for securities.
Yeah, and Coinbase has pushed back on that, so they're currently still fighting.
Right, they've said these are not securities. So anyway, as I read this and I really realized, this is the same split. It's still Gensler versus Pierce here, breaking out, but now the principles, as opposed to being opposed to crypto, are being applied to the private market. And so I think we really are going to have to watch this closely because, the crypto thing, as you and I know, we never talk about crypto on this podcast, but you and I track crypto. We know this fight's been going on for years between these two, and it's gotten really ugly. It's really ugly. And so this is the first sort of move in the private space. And I want to just read the quotes from Gensler and Pierce here. So Gensler's quote is, at the core was addressing some of the opacity in this field. Our investors, large or small, benefit from greater transparency. Right, so that feels like a very Gary Gensler kind of quote.
Right, it's hard to fight with that quote. Yeah.
And then Hester Pierce said, the rulemaking is ahistorical, unjustified, unlawful, impractical, confusing, and harmful. That sounds like Hester Pierce.
I wish I could have been a fly on the wall at that meeting.
And so, I think what's really interesting is that the way that I have always thought about our industry is the SEC does not allow everyday people to be involved in our industry.
Right.
And how they regulate it is they say, unless you're an accredited investor, you can't even play in this space, right? But if you're an accredited investor, it's pretty
it's assumed that if you're accredited, you can negotiate for yourself.
You can negotiate for yourself.
You understand this stuff and you can negotiate.
That's exactly right. You can negotiate for yourself, and we're going to let these organizations basically structure funds. We'll create some regulation around it. And there's a lot of stuff you can't do. Obviously, you read your Reg D and it'll tell you everything that you can't do. But in terms of the way that you structure it, the side letters is a really clear example of this. This is how funds are constructed today. Like if you have a fund and you have a major investor in it,
there's a side letter.
There's a side letter. Like that's how it's done. Okay. So, obviously, if there are no side letters, let me just say what is going to happen. I think it's going to be harder to get funds off the ground purely because the agreement called the limited partner agreement is going to take longer to get done.
Right.
It's going to have to be constantly amended because you're going to have LPs who are going to say, I must have this provision in our agreement. And because you can't have a side letter, everything has to be in the LPA. And so you're going to have to be constantly amending that. That's going to raise legal fees.
I think probably, I don't understand the legal stuff that well, but I believe the SEC is killing side letters.
Yeah.
They can't actually prevent side letters. So making you disclose all the side letters 100%, it ends up like you might as well just put it in the LPA.
You might as well put it in the LPA.
Right.
But that's going to make the LPA so unwieldy.
Yeah. And so, obviously, we're in this space and we have LPAs and side letters. So I have to say I'm not independent in this.
No, of course not.
But I agree with the MFA. So there's a lobbying group, a bunch of hedge funds that was in the Wall Street Journal. Their quote is, "This is going to increase costs, undermine competition, and reduce investment opportunities." Really, it's going to prevent new funds from having a reasonable chance to get up and get started.
It's going to functionally be a barrier to new funds.
Yeah.
That's exactly right.
I think it's like GDPR. Like it's a hassle for everybody.
Yeah.
But the big firms, they have Citadel, Bridgewater, Millennium in here, Apollo, Blackstone. Those funds have a lot of resources and they'll figure lots of LPs. They'll figure it out. And they won't let in some smaller LPs probably, which is not good for the overall market. But then a new firm, or maybe someone who had success there and wants to break off with two other partners and start a new private equity firm, which is healthy and the American way, is not going to be as easy to do.
No, because what typically happens is if you are a new fund, you generally have an anchor, which is someone who really likes you and wants to help you get off the ground. Right. With your fund one, you have no track record.
Right. And they get a side letter with a special deal.
Of course, when they're the anchor, they're going to say, hey, listen, because I'm basically getting you off the ground and legitimizing you.
Right.
Here's all the little benefits that I want. And that is not it's not favorable for you as the fund manager to have to disclose that to all the future investors you're trying to get to round out your fund.
Well, what'll happen
That's the practical
is everyone's
implication
going to have that deal. Right, so you're going to have to do it for...
Well, everyone's going to have it because you're going to have to disclose it, and then everyone's going to say, well, I want that too.
Right. Exactly. So
it's going to hurt the fund manager.
It's going to hurt the fund manager, and I think in a 5-year view, there will be fewer options.
Yes.
And so it'll hurt the investors too, because there will be less choice. And so I mean, I'm sort of more of a free markets perspective in general, and I'm totally biased in this because I have side letters. But I think that in the long run, the SEC is trying to bring transparency and free, sort of open opportunity to all the LPs in a fair world. But that's not what's going to happen.
No.
What'll happen is there'll be fewer choices, and only CalPERS and the really big LPs will get in.
Yeah. So I think the punchline is it will take some years for this to play out. But if this rule stands, I think this is more headwinds for early stage capital in the market.
Yes.
Less innovation
At a time when we don't need that.
That's right. That's the headline. Okay, and final financial story: the Atlanta Fed signaled that they have a model and that we should expect in the third quarter for GDP to get a 5.8% growth rate.
Yeah, and so the summary of this is
which is a lot, by the way.
Yeah, it's huge. We're getting taxed. I mean, it was basically flat, maybe just 1%, 2%. I think it was probably 1% in the second quarter. So it was slightly positive. This would be really big growth and wonderful. But the summary of these three stories to me is there increases taxes on a whole new way to tax. The SEC is coming after private equity in a way that's going to be a challenge and limit competition and new fund formation. And yet everything is going great and the economy is growing gangbusters. And I don't know if I believe that, but whether I believe it or not doesn't matter. This is the U.S. Fed, the Atlanta division of the Fed, coming out with its model, which says to me that their analysis is there's no reason to cut rates. Everything is going great.
That's right.
I mean, Powell will speak tomorrow from Jackson Hole, and who knows what he'll say. But this is, I think, a signal. I mean, of course he knows they put this out.
Yeah, of course.
I mean, they are showing that we're going to have a soft landing and everything will be fine, even though 2/3 of people have to start paying student loans and they have no idea how to do that.
Yeah. I mean, one of the big things they talk about here is how U.S. single-family home building surged in July and permits for future construction rose amid an acute shortage of previously owned homes.
Yeah, but that's because no one can move.
Exactly. Everyone's locked in. But what they're saying is home building's growing. That's good. This is good for the construction industry, right? Don't worry. We will house the people because we're going to grow our construction and our developing industry. So that's good.
I mean, the economy will do whatever it does, but it's pretty clear the Fed's not cutting anytime soon, in my mind.
And also, I think they're saying that rates are not stopping people from building homes, right? So new inventory will be created, and the rate is not prohibitive to that.
Yeah. Okay. I hope that's right.
All right. Final story. We're backing off of all the finance stuff. You found.
Let's get back to healthcare.
Yeah. You found this story in the New York Times, and I think we just can watch the New York Times probably every week for a great story on really the heart of healthcare. Yeah.
So the gender transition, gender clinics has been kind of a battleground and over politicized, or at least politicized.
Yeah.
We felt it here with Vanderbilt, but it's all over the country. It's all over the country. And I thought the New York Times did a really good job in this story. It's a long story, very detailed, but they talk about a Washington University kind of St. Louis-based clinic for children, teenagers that have concerns about their gender identity and are needing counseling and are considering whether they want to transition. And it takes a while to dig through, but the summary is it started off with, I think, 2 clinicians working maybe 10 hours a week, seeing patients. And they had a very organized process. You did counseling for a while. They did offer transition services with the medication to stop and everything. But it was very slow and methodical, and they had research backed on it and I think, very well done. And there's some percentage of people in the world that want to transition. And I think that's been true for a long time.
And there's a full process. It's not just like you want to transition,
you don't just get the meds immediately. And what happened is that they got flooded with people really suffering and wanting help where they couldn't see all the patients and they didn't have the capacity. So they did what any clinician would do, which is try to find other people to help with some of these patients.
Because volume is good in healthcare.
Volume is good, and they felt like there's a lot of people in need.
Of course. But
both. Like, we need money, but I don't know that these people were that focused on the money, that they were like a waiting list too long.
Yeah, but look, I'm not saying money from a profit perspective. I'm saying money as you need money to operate.
Yes.
Right. And so it's very hard. I mean, yes, you're looking at the child who needs help and needs support. And I'm sure is very desperate because there are not a lot of options for support anywhere in the world, I would imagine.
Yeah, I think they were driving from all over.
Yeah. But also, more volume equals more money equals more ability to do the work. Right. Because that's the way that it's set up.
Yeah. And so there are not a lot of clinicians in the country that are trained in this. There aren't enough clinicians in behavioral health at all.
Yeah.
In anything, definitely in behavioral health. And so my interpretation, and maybe it's the reporter's writing, but it seemed legitimate. They did the best they could. They hired people that were licensed, but maybe didn't have the same kind of extensive training in transgender work, but they were psychiatrists or counselors, or they're in this space, and more patients came. Like, the more they served, the more came.
Mm-hmm.
And then they added some contract labor, and they just couldn't train everyone quickly enough. And so there were several examples where teenagers, were granted medication without all the counseling and things, and it was not great outcomes. Some of the kids had bad experiences and now regret doing it, but unfortunately, it can cause irreversible damage. And so it just struck me as a balanced story of, like, the real problem is teenagers around St. Louis and in the surrounding areas. Mm-hmm. There's a lot of teenagers that are really confused, really suffering, that need help, and our system is not providing the help.
Principally, they need behavioral health support.
They need counseling. They need advice. They need support.
Right.
They want to consider their identity.
Right.
And they don't know where that will end. It might mean transitioning. It may mean that they, after considering it through several years of counseling, they decide not to. It may decide they go forward. They tried to answer the need, and they were not able to find clinicians, and it went badly. But I don't blame the people. I think the problem is we have a lot of patients that need behavioral help, and we don't have the systems to treat them.
We have a lot of patients. We have not a lot of clinicians, and we have a lot of pills.
Yeah, right.
It's just like Truepill and Cerebral, right?
Yeah. So eventually, the standards slip a little bit. Someone doesn't have quite the training. I take the assumption that no one did something intentionally bad, but people were harmed.
Yeah, assume best intent. Yeah.
But people were harmed. And the sad thing is that this hasn't ended. I mean, there's people today that are suffering. And so it just struck, I think it was a well-written story. We'll put a link to it. But it really highlights the challenge and the problem and the lack of behavioral health support in our country.
As difficult as it was, and I'm sure that I'm very much offering an opinion with no actual, insight at all into the situation. But from my seat, my Monday morning quarterback seat, having a really, really long waiting list and sticking with the really high caliber clinicians and making sure the process was executed at the highest and most pristine level.
That's the least bad thing you could do.
Would have been the least bad thing.
Yeah.
Right. That would have been the least bad thing.
Right.
And that is very, very hard. It's very, very hard, but it prevents the entire practice from being jeopardized.
Right.
Right. Which is kind of where I think this.
Well, and I think
especially in a highly politicized world where people are just looking for something like this, right?
And it's Hippocratic oath. Do no harm. I know that clinicians want to help the kids, but you have to first do no harm, right? And so I think you're exactly right. Having a long wait list and having only the experts working through this very regimented process.
And this is awful. I understand that what I'm saying.
It's bad. That's also bad.
It's awful. I understand
that. You have people on the wait list that are suffering. By definition, they're suffering. They need help. I understand that. But the alternative of rushing them through and finding someone who does marriage counseling and has a license in the state, but they've never treated this before, that is destined to have problems.
Yes.
It's just not going to work. So the answer is we need to train more clinicians, but that's 10 years, 20 years.
That's going to take a long time.
And we don't have people applying to do it.
That's going to take a long time.
So unfortunately, our society is creating people that have a lot of pain, a lot of confusion, a lot of behavioral health issues. I mean, the Truepill Adderall thing is also a behavioral health drug. I mean, it's just
people with ADHD are suffering.
Yeah,
that's
yeah.
All right. Well, look, we just an appeal. I mean, this is certainly one of our less positive episodes. But look, we are in a time of we are in a very, very challenging time. I don't think there's any question about it. I mean, I'm recognizing it in all the conversations I'm having, not just the ones I'm having with Vic on a weekly basis on this podcast, but with just people in healthcare, with my fellows in the Aspen Institute Health Innovators Fellowship, with, people I'm meeting in HFMA, with just friends of mine in the healthcare industry, my friends in the Nashville Healthcare, Fellows Program. This is a hard time in this industry. And I think we have to continue to try to talk through the problems, as depressing as they might be, because once we can get to what the root cause is, we can really start to innovate, and we can really start to find some solutions. And that's why I was giving kudos to Mark Cuban for his solution. His solution is a very good first principle solution, right? You know what I mean? Just take the unnecessary cost out of the drugs that are widely available. Yes, there's going to be some variance in the quality. That's a whole different issue. But the middleman, clearly, we don't need that right now. With all the other challenges we have from a cost perspective, we don't need that right now.
Yeah, and I think that there's a lot of hard issues, right? But what I like about having this conversation with you is that we can talk about a gender clinic, which is super emotionally charged, politically charged, and gets used for political purposes that have nothing to do with really helping the kids, and talk about the issues without sort of going to raising our voice and pointing fingers and saying that anyone did something intentionally bad.
Right.
And try to understand what's going on and what can we do that makes a incremental, let's make a small positive change. I mean, we make investments in companies that are bringing innovations to healthcare. There are so many places that need help. It's
a never-ending list.
Overwhelming.
It's a never-ending list.
Yes, but doing it for political reasons or to raise money or to put up some teenager on the front page of the paper is not the way to do it. So I like to point out this story because I think the Times did a good job sort of fleshing out a full story as opposed to just like a hit piece where they get the headline thing. And so I think that was good.
Yeah. Well, our system is challenged. It is a systems issue. It had a really flawed design, and it's an industry that should be regulated, but in a lot of ways, the regulation is dependent on the quality of our government, and right now we're very challenged in that respect, and so that makes it even harder. It makes our job as free market innovators that much harder.
Yeah, I mean, the reason I understand why Silicon Valley tries to roll over the regulations.
Yeah,
I mean,
sure.
It's
just not going to work.
It just doesn't. It's not successful.
No.
Right. If I thought it was going to work, I'd be doing it too.
Right.
I just think it's not the right strategy. But I understand the emotion of it. Like,
sure.
They're standing in the way. We need to find a solution. But it's too risky given the power of these regulatory bodies.
That's right. So next week we'll talk about Powell. It'll be my last week in the studio for I think just 1 week because I'm flying off to Worlds next Friday. So we're going to record in the studio before I fly off to Worlds. It'll be my last thing I do for work before I go.
That'll be good.
Focus.
I'll have a last word of encouragement before you go beat up a bunch of people.
Yeah. So I'm looking forward to seeing what Powell says, and hopefully we have some better, more positive things to talk about next week. We will search for some more positive things.
Find something.
Anyway, until next week.